All right, I'm gonna get started. Thanks for coming to joining this journal club. April 7th, 2025, ACVNU Journal Club. I'm going to present this paper, urine sodium concentration after intravenous furosemide in dogs with acute congestive heart failure and correction with treatment efficacy. My name is Ueda from North Carolina State University. Before jumping this paper to discuss, I want to review some diuretics. So in this journal club, I'm going to talk about the overview on the diuretics and also diuretic resistance, and then discuss about this paper. And then I'm going to talk about the this urine sodium concentration measurement and also the serum chloride concentration as the kind of part of the chloride theory as the cause of the diuretic resistance. So I'm going to get started with this review on the diuretics. As you guys already know, there are some common diuretics we use in the vet med, including loop diuretics that works on this thick ascending loop on the Henle here. Then sodium potassium 2 chloride transporters. There are some other common medication such as carbonic anhydrase inhibitor, acetozolamide that works on the proximal tubule, and also this thiazide that blocking or inhibiting sodium chloride co-transporter at the distal convoluted tubules. We oftentimes using that this mineralocorticoid receptor antagonist works on that this late distal convoluted tubule and also collecting duct. And it's not a common medication we use in the United States, but this vasopressin receptor antagonist, Baptan or tarbaptan, might be another medication that we can use as the diuretics, as a kind of removing the extra water from the body. And then especially among all these kind of the common diuretics, the loop diuretics is the most common medication we use in vet med for dogs and cats, including furosemide and torsemide. And as you know, and as I already mentioned, these loop diuretics inhibit the sodium potassium 2 chloride transporter at the thick ascending limb of the loop of the Henle. And then these transporters reabsorb about 25% of the filtered sodium chloride. About 60 to 70% of this sodium chloride are usually reabsorbed at the proximal tubule. And that's, of course, by inhibiting the sodium potassium 2 chloride transporters by giving the furosemide or torsemide loop diuretics, we can decrease that sodium and chloride reabsorption. So it's a water resorption. These loop diuretics also inhibit the same transporter, sodium potassium 2 chloride transporter at macula densa cells. That's special cells residing at the distal convoluted tubule. And then these macula densa cells are important chemoreceptor to sensing the sodium chloride, especially the chloride, and then that's enhancing the tubular glomerular feedback system, especially when there is a decreased GFR. And having that the decrease the chloride, sodium chloride sensed by the cells improve the GFR. But also this the activation of this system increasing the renin secretion from the juxtaglomerular cells, granule cells, that activate RAS, renin-angiotensin aldosterone system. As I kind of review this in the furosemide and the torsemide, this loop diuretics usually bound to the albumin and the proteins. So it's not going to be filtered through the glomerulus. So that's kind of delivered through the afferent arterioles, glomerular capillaries, and going through the efferent arterioles and going to peritubular capillaries, and eventually at the proximal tubules or peritubular capillary at the proximal tubule, releasing that this furosemide into the tubule lumen through the organic and ion transporters, OAT. And that's going to travel through the lumen, through that the loop of the Henle, and finally reaching that this thick ascending limb of the loop of the Henle, and inhibit sodium potassium 2 chloride transporters, working as a diuretics. And again, this tubular glomerular feedback system is an important feedback system in the body to maintain a glomerular filtration rate. When they have the decreased GFR and what are the reason, that's going to decrease in that the flow through the tubules, and that results in the decreased sodium chloride sensed by the macula densa cells at the distal tubule. And especially this is actually the chloride, but again, this is through the sodium potassium 2 chloride transporters on luminal membrane of the on the macula densa cells. And then the decreased sodium chloride at the macula densa eventually results in the dilation of the afferent arterioles, leading to the improved GFR, glomerular filtration rate. By having a loop diuretics in the system, that's going to further decrease in the sodium chloride sensed by the macula densa, leading to the improved or increased GFR. So that might be the other way that this loop diuretics, such as furosemide, acts as the diuretics by improving the GFR. However, this decrease in GFR and decreased sodium chloride sensed by the macula densa cells also activates the renin. And then this renin activated the RAS in renin-angiotensin aldosterone system. And that could actually result in that the more reabsorption of the sodium and also reabsorption of the water. So that could counteract the effect on diuretics by having that the RAS activation. So that could be the one mechanisms to cause the diuretic resistance in the body due to the RAS activations by giving that the furosemide, because again, the furosemide and loop diuretics further decrease in sodium chloride sensed by the macula densa, so further increase the renin secretion from the granule cells, so further enhancing the RAS activations, resulting that the reabsorption of water and the sodium. So when the patients have that the heart failure, they might have that this increase that the absorption the reabsorption of sodium in the water at the distal tubules and the collecting duct, and that might be the one significant mechanisms of the diuretic resistance. However, as you can see on this table or figure, there are many other reasons that patients could have the diuretic resistance. And then people sometimes kind of categorizing these causes and mechanisms of the diuretic resistance into the pre-renal effect, such as venous congestions, decreased albumin concentration, high sodium intake, and intrarenal causes. And that's further divided into the pre-loop of the Henle at the proximal convoluted tubule or glomerular level, or on the loop of the Henle and the post-loop of the Henle. Again, the most significant effect is this, the increased reabsorption of the sodium in the water at the distal convoluted tubule and the collecting duct by especially the enhanced RAS activations. But there are, again, many other effects, such as activation of the ENaC channels or transporters, or upregulation of other transporters, such as the sodium chloride co-transporters and the pendrin and the ENaC. And then I'm going to talk about this one a little bit more later at the discussion. Hypochloremia alkalosis is actually other major, one of the major contributors or mechanisms developing that the diuretic resistance. And then when they have this, they are increased that when they have this acute heart failure, decompensated heart failure, they have the decreased effect of the diuretics, such as loop diuretics, even if that they have same plasma concentrations. The sodium and chloride excretion could be suppressed or decreased compared to a healthy person by receiving the same amount or same dose of furosemide. They might get that the decreased sodium chloride excretions because of that. These multiple reasons we discussed so far, especially compensatory increased reabsorption of sodium in the water at the distal nephron. more focusing on that the loop diuretics and furosemide, there are many again these mechanisms causing a diuretic resistance, increasing including the reduced absorption of the furosemide from the GI system, and a decreased albumin binding due to hypoalbuminemia, reduced filtrations, proximal sodium resorptions, and also the inhibitions or competitive inhibition of the organic anion transporters, OAT transporters at the proximal tubules, and also that again, as we talk about it so far, this distal sodium reabsorptions due to increased RAS activations could be that other contributing factors for furosemide diuretic resistance. And again, the enhanced sodium resorption of the distal nephrons, including distal convoluted tubules and collecting duct, is kind of huge part of it in the patients with diuretic resistance. Like again, multiple times, the RAS activations, but also this nephron remodeling at the distal nephrons, including the distal convoluted tubules and collecting duct, including the enhanced sodium chloride co-transporters at the early distal convoluted tubules, or the increased sodium and water reabsorptions at the principal cells and the collecting duct, and also increased chloride resorptions, and then increased bicarbonate their secretions at the beta intercalated cells. All these kind of things could be increased by the hypertrophy and hyperplasia of these distal nephrons due to the chronic usage of the furosemide, resulting in diuretic resistance. So how we're going to diagnose in this resistance on the diuretics? There are multiple diagnostics or information we can get from the patients. Of course, the traditional and the classical way to diagnosing it is based on the urine output and the body weight changes after giving a diuretic such as furosemide. You can also measure the urine spectrogravity or urine osmolarity. And also, this is kind of main topic on today's paper, is measuring the serum sodium and the urine sodium concentrations and the chloride concentration of serum in the urine. And then based on that, these serum and the urine electrolytes, you can also get the ratio of the urinary sodium and potassium concentrations. And then the fractional excretion of the sodium has been also investigated to determine if the patient have the diuretic resistance. And then based on that, this diuretic resistant diagnosis, then maybe we can modify the treatment strategies if the patient have essentially decreased sodium excretion into urine due to decreased with urinary sodium concentration decrease, or decreased fractional excretion of sodium, low ratio of the urine sodium and potassium ratio, for example, then maybe based on this information, you may consider the modifying treatment by maybe adding another type of the diuretics, more than just loop diuretics, maybe adding the acetozolamide or thiazide. Or sometimes, they are correcting this low sodium concentration or low chloride concentration by giving the hypertonic saline. Might be that another treatment that the people has been discussing about. So again, this urine sodium concentration is another the one way that we can potentially diagnose in diuretic resistance in dogs and cats with the congestive heart failure. So that is reason that I chosen this paper. I know this paper sounds like more like a cardiology paper, but of course, cardiac heart and the kidney is always kind of talking each other. And then I thought this might be a good topic to talk about from the nephrology side. And then I actually did my PhD in the cardiology. So now I'm interested in the nephrology and the hemodialysis, but I've been always interested in this interaction of the kidney and the heart. That is other reason I decided this paper. So going to this paper, in details, the hypothesis in this paper was that the urine sodium concentration after IV fluid will be correlated with the duration of the treatment with a supplemental oxygen and the cumulative frequency of the successful discontinuation of the supplemental O2. That's, they call the DCSO2. So successful discontinuation of the supplemental O2 during the hospitalization. So to test this hypothesis, they did this retrospective study. And whenever we talk about retrospective study, this is more a hypothesis generating study. So they still put down this hypothesis, but essentially they're trying to get that more information so that they can do the future prospective studies by generating the hypothesis. So this is very preliminary data they are gathering and then publishing. This study is based on dogs with acute congestive heart failure, and the inclusion criteria including, again, dogs with acute congestive heart failure, or at least acute decompensation congestive heart failure. And also they focus on dogs with congestive heart failure treated with supplemental oxygen. And also that they collect the patients who got the urine sodium concentration measured within the 30 to 540 minutes, which is 9 hours after IV furosemide. Exclusion criteria in the study including administration of furosemide CRI, and then diagnosis the condition other than acute congestive heart failure during the hospitalizations. And then dogs that did not receive the supplemental oxygen, such as very stable heart failure patients, probably just need a readjustment of the diuretics and went home. These patients are excluded from this study. And they collected all this data based on the medical record. Again, this is retrospective studies. They collected the signalement of the patients, like age, sex, breed, and weight, and also dose and frequency of any chronically administered oral diuretics. So again, I said that this is acute congestive heart failure, but the patients could be on the furosemide and diuretics at home. And then just they need to come back to their hospital, the acute decompensation of the congestive heart failure, or maybe new congestive heart failure diagnosed by the clinicians in the hospital. They also collected the CBC and CAM information before the first furosemide administrations, including PCB, total solids or total protein, BUN, serum creatinine, serum sodium and potassium and chloride concentrations. They also collected information about the dose and the time of the index furosemide administrations. And the index furosemide administrations is IV fluid dose administered given the immediately preceding urinary sodium concentration measurement. So like the IV fluid that was given before the urine sodium concentration measurement. That's an index furosemide administration. And the total dose of the IV furosemide before the index administration was also recorded. So that said, the patient could have multiple doses on the IV fluid before even this index furosemide administration during the same hospitalizations. They just, they are called index furosemide. That one dose that was before the measuring that urine sodium concentration. And then also, of course, they measure or they collected the record from the medical record, including urinary electrolyte concentration, especially urinary sodium and potassium concentration. They did not measure the fractional excretion of the sodium and the other parameters I just mentioned on the previous slides as a potential markers for diuretic resistance. So they focus on this urinary sodium and potassium concentration and then the ratio of these two electrolytes in the urine. Again, the index furosemide administration is IV fluid dose given immediately preceding the urinary sodium measurement. And the time from this index furosemide administration to the urinary sodium concentration measurement was also collected from the medical record. And this duration varies quite a bit. The shortest time is 30 minutes after this index furosemide dose, up to 9 hours, which is 540 minutes. The reason they picked at this 9 hours is that in general, in this hospital, they usually give the furosemide every 8 to 9 minutes. So every 3 times a day. Of course, after they kind of got out of that, a little bit kind of emergency phase of the congestive heart failure, and they continue every 8 to 9 hours. That was kind of common regimen that was used in this hospital. That is why they picked this 9 hours, just kind of before the next dose of the furosemide. So within this 9 hours, but at least 30 minutes after giving the furosemide is a time that they allow to measure the urine sodium concentration after the index furosemide administration. And the primary outcome, they look at their time from the start of the supplemental oxygen therapy to the time of the discontinuation of the supplemental O2. Again, that's a DCSO2. They also look at the time from the admission to the hospital to the time of the discontinuation of the supplemental O2. They also look at the time from the drawing the blood, so getting the blood sample to measure the electrolytes and the BUN and PCB to the time of DCSO2, discontinuation of supplemental O2. But they kind of find very similar findings on these all three time points, like time O2, time admission, time for the blood drawing. So I just kind of focus on this time O2, the time from the start on the supplemental oxygen to the time of the discontinuation of the supplemental O2 in this presentation. And also the primary outcome include the probability of the discontinuation, successful discontinuation of the supplemental oxygen over the duration of the hospitalizations. So that's a cumulative frequency of the discontinuation of the supplemental oxygen. And the statistical analysis include correlation analysis by using a Spearman row analysis. And then the association study, they use that the non-paired t-test, Wilcox and rank-sum test, and the Fisher's exact test, depending on continuous or categorical variables. They did also regression analysis besides correlation analysis, including univariate and multivariable linear regression analysis. Kaplan-Meier and Cox proportional hazard methods was used for the survival analysis. So as a result, they were able to correct 59 dogs with congestive heart failure in this hospital between 2020 to 2023. They ended up excluding the 8 dogs, including 5 dogs with no oxygen supplement, and 2 dogs received the furosemide CRI, and 1 dog with urinary sodium concentration measured within 30 minutes after the index furosemide administration. So that was too early to measure urinary sodium concentration. So these 8 dogs were excluded from the analysis. And within this 51 dogs, they collected and analyzed all this signalement, including sex and mean age and median body weight, and breeds, and also the type of the cardiac disease as a cause of the congestive heart failure. And then the one thing that maybe I'm gonna mention here is that most of the patients are small patients, like as you guys imagine, these congestive heart failure patients. The median body weight was 7.5 kilogram. And then a lot of patients are mixed breeds, but there's a Cavalier King Charles Spaniel and Havanese are the 2 other common breeds they got in this study. And 86% of dogs had congestive heart failure due to mitral valve disease, and only 8% dogs had dilated cardiomyopathy. And then they had patients with that, of course, the congestive heart failure. So they are already in stage C or stage D of this mitral valve disease in the patient. So they are already clinical. They have the congestive heart failure. But if you look at the dose of their oral diuretics that they were receiving in the home before coming to hospitals, they are getting the less than 8 mg per kilogram per day of the furosemide, which is usually kind of cutoff values to say the patients have the stage D, kind of the refractory congestive heart failure. So the median furosemide dose that was receiving at home is about the 4 mg per kg per day with that interquarter range of 3.8 to 5.5. So most of them are not in the refractory stage D congestive heart failure, but 81% patients had the diuretics, furosemide already given at home before coming back in the hospital. And 19% dog had a furosemide or more potent the loop diuretics at home, 0.41 mg per kg per day. So these patients also getting that this furosemide, their medication at home. And then the 76% of these patients received the furosemide IV before the index furosemide administrations. So these patients had again that they got this furosemide before urinary sodium concentration measurement, but even before this index furosemide, a lot of patients got another dose of the furosemide up to around the 4 mg per kg as the median, and then the sorry, that they are 4 mg per kg, yes, 4 mg per kg of the furosemide is given before the index furosemide dose. And the median index dose of the furosemide before urine sodium concentration measurement was 2 mg per kg. And again, like I said, and the method and materials, there's a big range of the time frame that they get the urine sodium concentration after the index furosemide dose administrations. And then the median time from the index furosemide administration to that measurement of the urinary sodium concentration was 140 minutes. And the interquarter range was 90 to 210 minutes. So a little bit over 3 hours, 3.5 hours. And the urinary sodium and urinary potassium concentration in the urine after index furosemide was about 86 millimole per liter on the sodium and 39 millimole per liter on the potassium. But the range is very big, especially in the urinary sodium concentration. Range was from the 9 to 182 millimole per liter. So wide range of that urinary sodium concentration. As a result of the correlation studies, so they look at the correlation between the urinary electrolytes, especially in the urinary sodium concentration, with the serum biochemistry and the CBC results. And then they found a bunch of these significant correlations, but especially they found significant negative correlations between the BUN and urinary sodium concentration and the PCV and urinary sodium concentration. And then they also found a significant moderate positive correlation between the urinary sodium and the serum chloride concentration. So essentially that they find out that these hemo concentrations and maybe dehydrations with the high BUN and high PCB were negatively correlated with the urinary sodium concentrations. When there are hemoconcentrated, dehydrated, or having that the hemo concentrations, they have that the lower urinary excretion of sodium, which is very interesting findings. Probably they have the more kind of drive on the sodium reabsorptions due to RAS activation. I'm going to come back on this correlation between the urinary sodium and the serum chloride concentration later during the discussion. Oh, so and then this is at the kind of correlation graph showing that PCV as an x-axis and then urinary sodium concentration as a y-axis. And it's not that strong correlations, but there are fair negative correlation between these two parameters. It is more interesting that serum chloride and the urinary sodium concentration have moderate positive correlations. So when the serum chloride concentration is decreased, which is shown on the x-axis on this graph, the urinary sodium concentration also goes down. So there's a positive correlation between the two parameters. They also found out the mean urinary sodium concentration in the dogs receiving oral diuretics such as furosemide or torsemide at home was significantly lower than that the dogs are not receiving the diuretics at home, which makes sense that when they have the chronic usage of the furosemide, there are multiple reasons they can have that the decreased urinary sodium concentration with increased sodium avidity or retention in the kidneys, because of RAS activations, because of the hypertrophy and hyperpressure of the distal nephrons, including sodium chloride co-transporters, ENaC, pendrin, all those kind of the transporters. And eventually, within this cohort on the patients with congestive heart failure, acute congestive heart failure in dogs, the about 90% dogs achieved the successful discontinuation of the oxygen supplementation. And the time that from the initiation of the oxygen supplementation to the discontinuation of the oxygen supplementation, so this time O2 was significantly longer in dogs with lower urinary sodium concentration than those with higher urinary sodium concentrations. And then based on their regression analysis, they made a cutoff number of the 87 millimole per liter of the urinary sodium concentration. When the urinary sodium concentration was lower than the 87 millimole per liter, that their mean time between the initiation and the discontinuation of the oxygen supplementation was 24.2 hours, with a standard deviation of 2.6 hours. When the urinary sodium concentration was higher than 87 millimole per liter, the mean time from initiation to discontinuation of the oxygen supplementation was 16.6 hours, with a standard deviation of 1.7 hours. So that was a significantly different and significantly shorter with higher urinary sodium concentration. And the cumulative frequencies of the discontinuation of the oxygen supplementation was significantly higher in dogs with higher urinary sodium concentrations. So over time during the hospitalizations, they have that better success rate of the discontinuation of oxygen supplementations and the improvement of the clinical signs of the congestive heart failure when the patient have that higher urinary sodium concentration, like you can see on this graph. Again, based on the regression analysis, they made that this cutoff value of 87 millimole per liter. And also, if they compare that the outcome, especially that rate of the euthanasia and death during the hospitalizations, that the patients who had a lower urinary sodium concentration, again, less than 87 millimole per liter based on regression analysis, had a significantly higher rate of the euthanasia compared to patients have the higher urinary excretion of the sodium, more than 87 millimole per liter in the concentration. As you can see, that difference is very small. Death in the lower urinary sodium concentration group is like 15%. And then the patient's higher urinary sodium excretions in the urine had a death rate of the 4%, euthanasia rate in the 4%. So they found a lot of differences depending on the concentration of the sodium in the urine. The one thing they did not find a significant differences is body weight and also the probability of discontinuation of the oxygen supplementation. So if they look at it, this weight loss more than 3.3 or less than 3.3%, again, based on the regression analysis, there are no significant differences over the course of this hospitalization, like 48 hours, regarding that the discontinuation rate of the oxygen supplementations. So I'm going to come back on this later during the discussion too. So the main finding of this study is they find out higher urinary sodium concentration after IV furosemide administration was associated with a shorter treatment duration and a higher cumulative frequency success rate of the discontinuation of oxygen supplementation in dogs with acute congestive heart failure. They also find out that there are lower urinary sodium concentrations with the high BUN and PCB hemoconcentrated patients will probably decrease the perfusion to the kidney with the high BUN and low serum chloride concentrations. And then the patients with the oral diuretics such as furosemide and torsemide at home. So that's what they found on this paper. And from here, I'm going to discuss about this, the urinary sodium concentrations, what we know on the human patients, and what they found in this study. And I'm gonna just kind of touch base a little bit about this serum chloride concentration and association of that with the diuretic resistance. So according to human studies, like I just listed a few of the many studies, these multiple studies in human patients find out the reported the lower urinary sodium concentration was significantly associated with a longer duration of IV diuretic treatment such as furosemide at home and higher risk on death. And that has been reported in this 2018, 2020 papers and a 2021 paper. And this 2021 paper even actually showing that the high urine sodium concentration was associated with a shorter median duration IV administration and the duration of hospitalizations. So low urinary sodium concentration is not good, and high urine sodium concentration after that the diuretic administration was good on these studies. And based on these, the evidence and study findings, even some of that the societies and human medicine recommending the urine spot check after the furosemide or diuretic administrations. As an example, this European Society of Cardiology, they have this position statement from the heart failure treatment in the human patient. And as you can see in this algorithm of flow chart of the treatment and diagnostics of congestive heart failure patients, human patients, you can see the spot check of the urine sodium concentration in the middle of this flow chart. When they have these patients with congestive heart failure, they of course started with a furosemide or diuretics. And after that, the administration of diuretics, like furosemide, loop diuretics, they recommend checking that they are measuring that the urine sodium concentration after 2 hours of the furosemide administration. Then they also recommend measuring that the urine volume output about the 6 hours after furosemide administrations. And of course, if the patient have the high sodium concentration, more than 50 or 70 millimole per liter in the urine, and also urine output elevations, they can say patients are responding to the furosemide administrations, so they can continue the treatment with the same dose of the furosemide they gave before they spot the urine sodium concentration check and the urine volume output check. But if they are not having the high urine sodium concentration or not enough urine output, then they recommend increasing the furosemide diuretic dose, double the dose on these patients. And after that, they kind of continue to monitor the urine output. And then based on that, if the still patient not improving that the diuretics or natriuresis, they recommend adding another class of the diuretics, such as acetozolamide or amiloride, which is in the ENaC inhibitor, or giving the thiazide. If the patient have the diabetes as well, they sometimes use the SGLT2, the inhibitors. And they usually kind of recommend that checking that the urine spot sodium concentrations within 1 to 2 hours after furosemide administrations. Now also we have to keep in mind the natriuresis and diuresis are different. Natriuresis, of course, that's the loss of the sodium into the urine. Diuresis is that the loss of that the water into urine without increasing the urine volume output. And according to this study, and according to that, the previous studies, the weight loss and urine output was not significantly associated with the frequency of the successful discontinuation of the supplemental oxygen concentration. Which means that probably again, the natriuresis is maybe more important or as important as the diuresis. And when the patient have the successful recovery from the congestive heart failure, when we have the successful treatment of the congestive heart failure, we need to have the both diuresis with improved urine output, with natriuresis, with higher urinary sodium concentrations. But sometimes they improve still with the native uses without decreasing weight loss, without improving urine output, because maybe the redistribution of the fluid within that the intravascular, interstitial, and intracellular space plays a role in the resolution of the congestive heart failure, not only just in the increase in urine diuresis with an increase in urine output in these patients after the diuretic administrations. So that might be the other kind of the potential findings based on that what they found about the non-significant differences between the patients in that body weight between the patients with a successful and non-successful discontinuation of the oxygen supplementations. So again, these findings also kind of implies that both body weight and urine output measurement and the urinary sodium concentration to assess that nature uses are important to decide if the diuretic therapy is effective or not. Maybe this is a little bit kind of extension, just too much extension from the findings on these retrospective studies, but I think at least these kind of the findings are indicated by the studies, so that I think the further studies indicated based on these findings. And again, coming back on these findings, which is very intriguing. So they found the urinary sodium and the serum chloride concentration were moderately significantly correlated. And so as the serum chloride concentration decreases, the urinary sodium concentration decreases. So that tells us maybe the serum chloride can also be used as a marker of the diuretic resistance. And then, as you can see here, this the urinary sodium concentration and the serum chloride concentration were even more strongly associated each other, more than PCB and more than oral diuretics at home. And if you look at more some recent studies, such as this paper on this slide, showing that the correlation the sodium chloride concentration causes congestive heart failure. And this study found out that the patients with heart failure, congestive heart failure, meaning the stage C or D, these are refractory congestive heart failure, usually furosemide more than 8 mg per kg per day. These patients have the low chloride concentration more than the patients with no congestive heart failure. And this low chloride concentration, both measured and corrected chloride concentration, were more significantly lower than that the patients, dogs with a stage C. So these patients have that either the more dilution or like more hemodilutions or water retention. And also maybe there's a depletion of the chloride because both measured and corrected chloride concentration were lower in the stage C and D, and especially in the stage D the patients. And this same study group from the Florida, University of Florida, also kind of they published some other papers, and then they found out hypochloremia, low chloride concentration, was associated with the neurohormonal activation, especially renin secretions. Again, as we talked about in the very beginning, due to that the activations or decreased chloride, sodium chloride, especially the chloride sensed by the macula densa, that increases the GFR, but also increase in renin secretion from the granular cells, juxtaglomerular cells. That's going to increase in sodium retention, reabsorption at the distal nephron. And then that is associated with the diuretic resistance in these previous studies, and also associated with poor outcome. And also, this hypochloremia is a better predictor of the stage D refractory congestive heart failure. And then these patients is a refractory congestive heart failure stage D patients have that, again, based on the previous studies in 2020, find out the increased RAS activations with increased angiotensin 1 and angiotensin 1 to 7 profile of the concentration in this RAS profiling study. Again, this is suspected based on that the previous studies and these current studies, low serum chloride tends to increase the renal sodium avidity retention of the sodium and a decrease in the urinary sodium concentration because of that RAS activations, like you can see in these profiling studies. That's due to that sodium potassium 2 chloride and macular densa inhibition. So again, this is a little bit kind of off topic from the urinary sodium concentration, but of course, as usual, sodium and chloride always kind of having that some interactions and a close relationship. That's why I'm talking about this chloride as well. There are some like the studies kind of focusing more this chloride therapy, chloride theory as that the cause of the diuretic resistance, and they are proposing some like the treatment modification of the congestive heart failure based on the serum chloride concentrations. And like as you can see here, this is just one example that the management plan based on the sodium, the chloride concentration, not the sodium. If that chloride is low in the serum, they look at it measured or corrected chloride concentration. If the only measured the chloride concentration is decreased, that's usually due to the water retentions with hemodilutions. Then maybe you might have to kind of focus on the more fluid restrictions and increasing that the loop diuretic dose. Or maybe like using the tolvaptan as the vasopressin receptor antagonist. If the patient have that their low corrected chloride concentration as well as a low measured chloride concentration, that's a chloride depletion. If they have the chloride depletion, maybe you might have to use that diuretics, that's a chloride sparing effect, such as acetozolamide or the spironolactone, that's a mineralocorticoid receptor antagonist. Maybe you might have to give that chloride to restore that normal serum chloride concentration by giving that sodium chloride hypertonic saline, or people maybe using the lysine chloride or maybe KCl, potassium chloride, if the patients have the concurrent hypokalemia. So going back to these studies, the limitations, there's of course a lot of limitations. There is stemmed from that the fact that this study is a retrospective study. And they only included dogs for which clinician chose to perform urinary sodium measurement. So that's not that just a regular sodium the congestive heart failure patient. They actually select the patients for which clinician chose to perform sodium concentration measurement in the urine. And also, they cannot assess what, if any, actions clinicians might have performed based on their knowledge of the urinary sodium concentration that could have influenced results, meaning that they might actually already modify the treatment based on the urinary sodium concentrations. Maybe they increase that the furosemide concentration. Maybe that's why the patient have the better success rate of the discontinuation of the supplemental oxygen. So that this association to the outcome to the urinary sodium concentration might be biased based on that the fact that the investigators and clinicians know that what the urinary sodium concentration in these patients. And also, they did not see the other common the parameters and then variables indicating that diuretic resistance, such as fractional excretion of the sodium, urine-specific gravities, and electrolyte-free water clearance, or any changes in serum and urine electrolyte concentration over time. So not the spot check, checking that they're over time for 3-4 hours. These kind of things has not been done in these studies. They try to rule out other common diseases, but there is no other measures on disease severities. How bad their left atrial enlargement, how bad the DCM. These things has not been incorporated in this study assessment. And also, they did not completely rule out that primary disease, other concurrent diseases, such as primary AL diseases, although they're trying to rule out the patients with non-congestive heart failure disease. So as a conclusion, like I said, they found a wide range of the urinary sodium concentration after IV fluid administration in dogs with acute congestive heart failure. Maybe that depending on the severity of the congestive heart failure. But again, like I said at the beginning, many of the patients in this study group already had a chronic furosemide and torsemide treatment at home. Also, they got one or more doses of the IV furosemide before the index furosemide administrations. So these variabilities may be caused at this wide range of the urinary sodium concentrations. So again, this tells us that prospective study is necessary. And a low urinary sodium concentration was associated with a significant predictor of the treatment duration and a successful discontinuation of the supplemental oxygen concentrations. Again, there might be some bias based on that their findings on the urinary sodium concentrations, and the clinician already might change the treatment plan, and also even the duration of the hospitalizations based on the urinary sodium concentrations. So we have to be careful to interpret these findings, especially in association with outcome. But at least they find out the low urinary sodium concentration in this study group with congestive heart failure was associated with chronic oral diuretic administrations and a low serum chloride concentration and high PCB and BUN. So questions for the future research. Again, this is retrospective studies. There are a lot of things that we need to do to determine this evidence. We need to find out the timing of the urine collection and measurement of the urinary sodium concentrations. They measure this urinary sodium concentration, this study, between that 30 minutes, 9 hours, big range of that. So they might have to have the studies, prospective studies, to have the same timing to get that urine sodium concentration. Or maybe they might have to compare that to the measurement of the urinary sodium concentration over time over like 9 hours. Can we just kind of get that these numbers in a voided urine, or do we have to place an UCAS? Do we measure serial monitoring the urinary sodium concentration or other related markers? Can we modify the treatment based on the urinary sodium concentrations? And does it affect the short and long-term clinical outcomes? Are there any associations between the urinary sodium concentration and other variables, including serum and urine chloride concentrations? And then is there any use of the non-loop diuretics impact on urinary sodium concentrations? Thiazide, acetazolamide, are they kind of affecting these urinary sodium concentrations? And again, as we talk about it during discussions, we focus on urinary sodium concentration. There are many evidence about the urinary sodium concentrations as a marker of the diuretics, diuretic resistance. But is it actually better to look at a serum chloride or urinary chloride concentrations, like we talk about it during the discussion? So this is kind of some of the literature that there might be interesting for you. Dr. Mark Oyama from Penn, he has very nice review papers in JVIM. You might already read that, but if you're not, this kind of summarizing that how to quantify the loop diuretic responsiveness or diuretic resistance for the congestive heart failure. And then there are many other good papers about diuretic therapy for the patients' heart failure and the human patients. And then, like I said, like we discussed and during the discussion, there are more and more papers talking about the chloride theory of the diuretic resistance to discuss and serum and also urine chloride concentrations to determine that the diuretic responsiveness and resistance in the human patient with heart failure. So that might be something that we might have to investigate more in dogs and cats with congestive heart failure. That's my last slide. And then, sorry, I just kind of went over a little bit, but if you have any questions, I'm happy to answer any questions.
Thanks, Dr. Ueda. That was great. Really thorough review. I think it's really enlightening and probably highlights the role of looking at urine electrolytes, particularly urine sodium in these patients. And I was wondering if anyone is starting to do that. I mean, certainly our heart failure patients are really managed more so by our cardiology team, and we don't really tend to get involved too much, which is maybe something that we should change and be able to provide some assistance. But for us in private practice, the fastest that we'll be able to get a urine sodium turned around is usually the next day because we have to send it out. We don't have the luxury of being in academia where you might have that as a possibility. But is that something that people have the ability to do in-house? How quickly are you getting the results? And is that something that anyone's actually started looking at yet? Because certainly this would suggest that there's a reason to look at it a lot further.
Yeah, in my hospital, yes, we can run, it's not a point of care testing that we can measure in ER, but if we send it to the central lab, they can measure and they can get the results back to us within a couple hours. So that potentially can change our treatment based on what's going on in the patients. In the previous place I was working, they have this blood gas from the radiometer. The certain blood gas machine you can measure that the urine electrolyte concentrations. The one I have in my hospital now at the NC State we cannot measure. So most of the blood gas machine we cannot measure, but the certain of them can be utilized for measuring the urine sodium concentrations. And then the like you said, JD, I agree. I think a lot of times this interest in the heart failure patients really kind of measured by the cardiology people. But I think it's of course a disease with not only cardiac disease but also renal disease. There's a significant interaction between these two organs. So I feel me as at the ECC, the criticalist and also nephrology resident, I feel that we should be involved in this management of the heart failure patients more.
Yeah, I agree 100%. And what's interesting is that you look at the range of urine sodiums that were measured, that were obtained in this study. Some of them, I think the lowest went down to what, 9 or
Yeah.
so. So, the blood gas analyzers, they just might not even be, they might not be validated for such low measurements. If you look at their calibration curve, they're probably quite accurate from the physiologic range for serum or plasma samples. And so between maybe 120 and 180, they're going to be really tight. And then as you go above and beyond the accuracy of all, of quality control testing is going to start to skew some. So you wonder for such a huge range of sodiums, how valid that would be. We've certainly tried to get our lab to run it, and they insist that running urine through their blood gas analyzer would blow up the machine and it's going to break. Or they can't interpret it, which is fine because I'm not expecting them to. But you also just wonder, if it's going to be 20, is that actually accurate, or maybe it doesn't have to be, is it, if it's 20 but it's actually 15 or 25 or 5, it still might be well below that cutoff that you might not have the exact number, but it might be more so qualitative. Is it less than, you look at the human guidelines anywhere from like 50 to 75 that is used. This study may be about 90 or 100. Maybe it just needs to be close enough rather than perfectly accurate, but that something to remember that, just because your iStat machine gives you a result doesn't mean it's necessarily accurate at those levels.
Yeah, 100% agree. Yes, I like you said, I think doesn't have to be as accurate as um the serum sodium concentration that we are measuring, but I think that we really have no idea how different it is. Maybe that's another study we will have to do to compare and then just kind of get the validations of this super low, severe low numbers and severe high numbers. Even the blood gas machine that we have in here in the ER at the NC State, that's a human product. So they even cannot provide these values that was not validated in the human patients. So my understanding, these machines actually can measure this severe super low number and super high number, but they don't give us numbers because that was not validated in the human patients too. So I think that's a significant issues that we need to solve before started measuring all these kind of numbers. I 100% agree. Any other questions? Great. Thank you. Thank you, Jody, for your comments and questions.
Great work. Really enjoyed the presentation.
Thank you. All right, see you guys next time. Thank you. Thanks for
you.
attending.